Let me introduce tonight's speaker. Her name is Dr. Wendy Grube. Grube, I'm sorry. Grube, that's what I thought. I apologize, yep. Wendy.
Okay.
So I've worked with Wendy in the past, and she's now semi-retired, but is still serving as an adjunct practice associate professor at the University of Pennsylvania, where she previously served as the director of the Center for Global Women's Health and director of the Women's Health Gender-Related Nurse Practitioner Program at the UPenn School of Nursing. Her research has focused on promoting access to reproductive and preventive health care for underserved populations across the globe, and she has informed state and regional providers and providers in other countries and health advocates in the development of culturally appropriate care, including care for trans folk. She's the co-creator of the Global Nursing Fellowship Program, which was designed to build nursing and allied healthcare worker capacity around the globe. She holds a PhD, is a certified nurse practitioner, and is a distinguished fellow of the American Academy of Nursing. So welcome, Wendy, and Wendy's cat.
Serafina, right? Serafina taking it.
Nice to see you.
The timing is incredible. Anyway, thank you so much. And I really appreciate this opportunity to share the information that I have and maybe start a conversation around some of these issues. And let's see if I can actually advance this here. There it goes. Okay. And so, just even thinking about barriers to care, and please stop me if this is redundant from previous presentations, but, there's a serious issue related specifically to sexual and reproductive health care among trans men. What we know from a very large national survey that was done through the Trans Equity Organization, it showed that approximately 1/4, like 1 out of every 4 trans men just really didn't have adequate insurance to cover the needs. And that could be screening, it could be hormonal care, and it could be surgery. Also, 1/3 of folks, about 1/3, experience mistreatment by healthcare providers. And I think that that's a real critical issue. And I think you covered that. Did you? That was discussed in the last presentation pretty much, yeah.
Yeah, but we will have people here who weren't on the last presentation, so it's good to do this stuff.
It makes a huge difference. And again, trying to find somebody that you're comfortable in speaking with, and somebody who's informed in trans care. You shouldn't have to be the teacher to your provider, regarding your care. A number of statements have been reported by people who experienced uncomfortable situations with their healthcare providers where, there were questions that were totally inappropriate to the exam that were being asked by the provider who was just basically curious. But that's not their job. Their job at this time is to be a sensitive and compassionate healthcare provider, an informed healthcare provider for your needs. Common health problems. And I think that it's important to put these all in perspective, but there's a lot of overlap here. So certainly emotional and psychological abuse is one of the most significant things that have been reported again. And this was from a review of the literature done and reported by the Mayo Clinic. Physical and sexual violence. And, again, they go together, they're linked together. And along with them as well is the increased risk of sexually transmitted infections. We'll talk about this separately. Also viral hepatitis and HIV. Substance misuse is common, again, linked up with emotional and psychological and physical abuse and mental health problems that are commonly associated with all of this. Again, they're all interconnected. So the recommendations, what we're going to talk about really for the purpose of this hour, is really what kind of preventive health screening that you need. and why, and also, how you can help to be an advocate on your own behalf and negotiate your care, just so you know what's possible. And again, how you can reach a compromise perhaps with your healthcare provider. So these are the things that are recommended. If you have a cervix, it needs to be screened. You have a body part, and there's screening for that body part, you got to do it. Also, a chest exam needs to be done periodically. And that it doesn't matter whether or not you have glandular tissue. A chest exam is important to be done. Hormonal care needs to be evaluated, routine infection screening, because again, the majority of infections can be asymptomatic. You have no symptoms whatsoever. And also sometimes people think, well, if I go to a clinic and I pee in a cup for an infection, that's going to catch everything. When there are a lot of infections that can actually occur in the mucous membranes in the mouth and the anus. And you may not even think about that. So what we know is that there's, again, a big discrepancy in folks who had, even with insurance, who were denied coverage for services that were considered to be gender specific. So if all of your information identifies you as a man, and you're there for cervical screening for a pap smear, your insurance may deny that. Because if you're a man, you shouldn't, according to their, perspective, you shouldn't have cervix. So I think that those are things that are slowly changing. They are changing. Also, some folks, if you identify as a man, and this is put on your gender identification form for your cervical cancer screening, they may assume that it's an anal pap. Because again, many men now are getting anal paps to screen for human papillomaviruses. So again, you need to be very clear. Again, your provider needs to be very clear about what site is being screened. And also, again, trans men can be denied coverage, again, for something like cervical cancer screening.
And I think, to your point about that, it's easy to be denied these coverage. I know that, for myself, as I'm a trans woman, but I still have a prostate, and it's easy for my prostate exams not to be covered, or my prostate test not to be covered. But if you work with your doctors often in advance, they can make sure that your records are appropriately updated and advocate on your behalf sort of in advance if they know that that may be an issue with your insurance company.
Right. And the insurance company, well, the lab looks at these forms when they come in. It really starts at the lab. They look at the form and they don't quite put the pieces together. They have no idea. They think something is mislabeled. So that's why this communication all down the line on the form by the provider to the lab and then to the insurance company, the communication has to be very clear all along.
Yeah. And I think, so we just got a couple great comments that, so maybe you could talk a little bit more about what types of infections are important to be screened for.
Absolutely. Yep. We're going to kind of go systematically down this screening thing.
Okay.
So first of all, just to start in a big picture is looking at all the body changes that happen for trans guys. I like the term, Corinne, when you sent me the term trans guys, I'm so used to saying trans men, but you know what? There's folks that are transitioning that really don't consider themselves men yet because they're teens or youngsters, so trans guys, I like that. Anyway, of all the folks who were considering themselves or who were gender identified as female when they were born and identify as men, 78% of them said they wanted hormones in this big national survey. 78%, that's a lot. Less than 50% actually got them. But let's take a look at some of these changes that happen, again, in your body when you do get hormones, when you're taking testosterone, whether you're taking it by mouth or injection or through your skin. So, there's some of this stuff that you can see that changes very visibly, and they connect directly with your identification as a man, which is the facial hair, and the chest hair and the coarseness of the hair. And also muscle mass. All of a sudden, you know, you really have increase in muscle mass and body weight, and you're stronger. So these things really change. There are some things that you may notice also in terms of your mood. Your dysphoria can decrease, and generally depression decreases, and you have less stress. And sometimes this connects directly with when you look in that mirror and you see somebody who most accurately reflects how you feel, you know, it's very self-affirming. So one of the, you know, so you expect your voice to go down in pitch as well. And the chest, your breast tissue on your chest actually begins to change as well. The glands decrease. What you don't necessarily expect is the amount of acne that you may get. So that is directly stimulated. It's not because your skin is dirty or you don't wash it enough. It really has to do with the testosterone, again, stimulating the production of sebum in your skin. So, you know, you will need to, there's some things that you can do topically that can really help with that. So that's something to really talk to your healthcare provider about. Some of the more hidden things that you don't notice but are certainly going on is your blood pressure can change, as well as your cholesterol. So the bad cholesterol goes up, the good cholesterol goes down, and that pretty much sucks. So again, you know, you really need to be careful about that. Other things that you may notice are some changes in the external and internal genitals. So you'll notice that monthly bleeding usually stops at about 6 months after using testosterone. And the actual erectile tissue increases on the external genitals. So that's going to increase. Now, the internal genitals, you're going to go from a thickness that may be 20 some cells thick down to maybe 10 cells. So the skin in the internal genital area becomes more fragile and less moist. So there are changes that happen there. And of course, sex desire definitely goes up. There's also some hair changes on your head that can change with testosterone use. Again, you can get thinning of the hair that's directly related to testosterone, as well as a receding hairline.
Can we talk a little bit about, so with those internal changes, with less thickness to the internal organs, what are some of the repercussions of that, you know, in terms, so, you know, if you still have an active sex life, for example?
Right. So, and again, I have some, and another slide coming up, a little bit more information about that. But what happens is, again, with this more fragile and delicate tissue now, it's the thicker the skin in the internal genitals, the more resilient it is. And again, it has usually a little bit more lubrication. So again, it's going to be less mucousy, less lubrication, more fragile, and you're more likely to have inflammation, irritation, and also little what we call microtrauma, little breaks in the mucosa, in the mucous membranes there that can increase your likelihood of getting certain infections. And we'll talk about that later when we look at the actual infections that you can get, including human papillomaviruses. So that definitely increases. Now, another thing that I don't see here is what happens is, again, an increased risk of urinary tract infections. And that can happen depending on whether or not you've had bottom surgery. If you were born with what has been considered, you know, female urethra, it's very small and it's very short. And when actually the when the mucous membranes decrease in size all around the external genitals, they also become very thin in the urethra, and bacteria from the bottom, from the external genitals, can actually be transmitted up through that little short urethra and give you more likelihood of having bladder infection. So you really need to be careful about things like oral sex, and also, you know, again, just basically how you wipe after urination and defecation. So First thing we'll talk about is cervical cancer screening. I mean, there are very significant risks for not being screened. Some folks think, well, you know, now that I'm on testosterone, I am not at risk for human papillomavirus infections. So what we know about cervical cancer is the main risk for getting invasive cervical cancer is not being screened. It's not necessarily just being exposed to human papillomavirus. What we know is among folks who have sex, about 80% of us or more are going to have HPV at some time in your life. Usually it's transient. If you have a healthy body, it goes away by itself. But sometimes it doesn't. So if you have a body part that requires screening, like a cervix, you need to monitor it. If you find a few abnormal cells, you remove them. You take care of it. No one in this day and age should ever get cervical cancer. And again, the highest risk is from no screening. So I know that it's really uncomfortable, again, for folks who have significant anatomical gender dysphoria, you know, where you're so uncomfortable, even like thinking about your external genitals, it can be really uncomfortable to go for an exam. So thinking about, though, what else you can do to reduce your risk. HPV vaccine really does help reduce the risk. And now the HPV-9, which covers 9 of the most significant cancer-causing HPV subtypes, this can actually decrease your risk by about 95%. So that's really significant. And also, if you happen to have sex with a male partner who has a penis, and you have insertive sex, you can actually get infections that way. So condom use, you know, it can be really important in preventing, especially if it's like somebody who is like, who you don't know very well, you haven't really had a long-term relationship with, you know, you might want to consider using a condom. Then we know it decreases the risk of multiple infections.
So here's a question about the HPV-9 vaccine.
Yep.
Can you fill us in a little bit around, you know, the availability of that and if there's an age range for that?
It should be available. It should be available through your primary care. And if not, your primary care can refer you. You can definitely get the screening anywhere from teenager to for transmit. I'm not sure exactly what age they're going to now, but I know it has extended beyond the 26, and I think it goes into the mid-30s right now. But I could check on that, or you can ask your provider. But it definitely is worthwhile to get the HPV vaccine. And again, HPV is the kind of thing that, you know, can be, you know, certainly have no symptoms, for sure have no symptoms. The other thing is trying to identify a good provider. And what a good provider means is somebody that you personally are going to be comfortable with. And usually word of mouth can help you find somebody who would be a respectful and knowledgeable provider for you. What we know, again, this is from a survey that UCSF quoted from in their guidelines, said that only 27% of trans men have reported having cervical cancer screening in the past year. So things that you can do to make it better. If you're talking to a provider, ask about the possibility of a self-collected HPV screening. If this is something that you might be interested in, if you're more comfortable in touching your genitals, external and internal, it might be easier to actually do a self-collected HPV. And that's just a small, it's a small little brush that's very soft that you would insert and then rotate in the internal genital area and then send off to a lab. Your provider can do that as well, but some people feel like they would like to do that themselves. Also, you can ask the provider if they, you know, if you can't do a self-collected test and they need to do an internal exam, to use something called a virginal speculum. Now, this is not a pediatric speculum. A pediatric speculum, a pediatric speculum is really short. A virginal speculum for an adult person with internal genital organs, it's called a Huffman. It's about as wide as my finger. It's 1.5 centimeters wide, but it's the proper length to be able to get to a cervix, because you don't want somebody just poking and poking and poking until they find it. Make sure that it's the right tool. They can also lubricate that with water or a little bit of lubrication jelly, not a lot, but just a little. Now, some folks actually have such delicate internal genital skin that just the act of using a speculum can cause bleeding. And these may be folks that don't have penetrative sex often, or use sex toys or whatever. And so those folks can actually be helped by using an estrogen tablet that's inserted into the internal genital area. And you use it every night for about a week before the exam. It's nothing that's absorbed systemically. It's not going to interfere with the testosterone at all. It just works on the skin in the internal genital area. It thickens the skin, creates a little bit more resilience, and therefore usually you can get a good sample. Also, you can ask to insert the speculum yourself if you feel more comfortable in doing that. But those are kind of ways that you can negotiate a better exam, but you need to do it. Again, the risk for HPV is there. And HPV, so let's say that this might be someone that you have oral sex with or anal sex with. HPV sweeps the entire genital tract. Even if you've not had insertive sex with a partner with an external genital organ, with a penis, even if you haven't had inserted sex, you can still get HPV. You can get HPV from dildos. You can get HPV from anything that causes micro trauma, those little breaks in the skin. And remember, that skin is going to be more delicate than usual. It doesn't take that much to break the skin. But you can transmit it from another partner, even through dildos or through infected articles. So, this is something that can happen. And you're also going to need to, again, make sure that your provider checks the whole area and checks your mouth.
So here's just a comment. Somebody said, it would be helpful if primary care providers or OBGYNs, asked a patient if they would need an estrogen tablet. So it can be sent to the pharmacy ahead of time, before the exam. Is that something that, I don't know, can be negotiated with the doc or put into your chart maybe as a note? Absolutely.
Absolutely. Especially for somebody who's been on testosterone for a while, or hormone blockers. It doesn't matter which, anything that is stopping, it's natural estrogen that causes that tissue in the internal genitals to become thick and resilient. And again, without the estrogen, it's not going to happen. So anything that's blocking estrogen can again create those same kinds of changes. So those little vaginal tablets, they're really easy to use. They're easy to insert. They're not goopy or messy, and it works really well.
And I guess, there are gels available as well. So if you didn't want to do the tablet thing, you could use like Estrace or something like that.
You still have to use an inserter to get it in, though. And the thing with, usually the tablets have a very set amount and they're less messy and people seem to prefer them. But yes, you could have either one. Yeah. Either the cream or the tablets.
And maybe I'm getting ahead here, and I apologize if I am to say so. But I would think that, if I was a trans guy, certainly when I was presenting male back in the day, and if I accompanied my spouse to the OB's office, I felt awkward as a guy there. And I would think that, as a trans guy, who, is getting hairy and has a deeper voice, and if you're going there to your OB's office for a pelvic exam, for a PAP or other care, that could feel really awkward. Do you have any thoughts on maybe ways, and maybe some of our audience members have some thoughts on ways that they can negotiate that, right? I would think that for myself, I would always try to be like the first appointment of the day, maybe.
Yep, I think that's helpful. But also, let people know ahead of time. Again, if you're getting testosterone, you're probably seeing somebody who's managing that. And it could be an endocrine, maybe not somebody you go to for reproductive health kind of things. But, ahead of time, I think you need to be, again, as assertive as you can on your own behalf to say, this is what I'm comfortable with. This is what I'm not comfortable with. And I know that for folks who have been really uncomfortable altogether, I have made appointments in succession. So the first appointment, just listening to heart, lungs, checking thyroid, and doing a chest exam. That's the first part, and then the second part might be doing abdominal and then a pelvic exam, those kinds of things. But you can certainly do this in stages, and you can do this at your own comfort level. But I think, again, you need to make a point to speak up and make your concerns known. You have the right to respectful and good sexual and reproductive health care. That's a right that you have. So, if you can speak up, you're more likely to get the kind of care that you really want. And some people, they don't mind too much. Other people mind a lot. So, this is something that your provider, isn't a mind reader. So, and they may or may not ask. So you need to speak up.
Perfect. So
chest exams, people think, well, if I had top surgery, I don't need a chest exam. You do. Even mastectomy, bilateral mastectomies does not remove all glandular tissue. Some glandular tissue remains. And you can't follow this up with a mammogram. There's no way you're going to do that. So what you need to do is you should be aware of things to look for and how to do your own chest exam. You need to know your family history. Again, breast cancer can and cannot be genetic. But you also should have an exam by somebody who knows what to look for. And again, knows how to evaluate someone after they've had top surgery. They're not routinely needed. But again, if you check yourself periodically at home and you find something that's disconcerting, you need to call up and make an exam. And usually how the follow-up goes for that is an ultrasound. It's not the kind of ultrasound that's in an OBGYN's office. It's the kind of ultrasound, it's a very specific ultrasound that is used for something that's a short distance rather than a long distance, like in the pelvis. So again, it's not routine, but you should certainly, make sure that you have periodic evaluations, especially if you're concerned. So this is the part that I think, most people get really freaked out about, which is, STI screening and prevention. Well, prevention is much better than, waiting till you have symptoms. Because again, they say 50% of all gonorrhea patients or gonorrhea people who are infected with gonorrhea have no symptoms. And about 75 to 80% of people with chlamydia have no symptoms. That's significant. That's really significant. And nobody gives somebody an infection on purpose. These are acts that happen with love. And so it's not to blame anybody, but certainly if you have symptoms, get checked. If you have a new partner, you may want to bring both of you in and get checked. And again, it's not just urine in a cup check. There are some exam parts that really should happen. So chlamydia and gonorrhea, easy enough with urination, right? Make sure to check the rectum. If you have, especially if you have anal sex, or the throat, because gonorrhea in the throat and the rectum are treated a little bit different than gonorrhea in internal genital areas. Again, so make sure that you check that. HIV rates, again, almost 5 times higher than the general population. Be aware of that. And there's certainly PrEP. If you're concerned about this, you can certainly use a pre-exposure prophylaxis medication, which is very available right now. So things to think about is the type of sex partner that you're having, the types of sex that you're having, whether or not you decide you're going to use condoms. Even if you're using sex toys, how you clean them afterwards is really important, because we know that you can get certain infections, especially HPV, from sex toys. And then again, screening all body areas is really important. And if you have something that you're concerned about, make sure you say something. I had someone who was very, very concerned about, what they thought were hemorrhoids that were growing larger, and they were really external genital warts. Now, they are not associated with cancer. They are relatively easy to treat, but you really need, if something like this comes up and you have a question as to what this is, be seen and get it cared for. So other genital issues that come up. Now, these are mostly internal genital issues. So all of a sudden, if you start noting some discharges, a bunch of things it could be. Most people think, oh, if you have internal genital organs, it's got to be a yeast infection. I mean, that's kind of the go-to. And usually it is not. The most common infection is something that's called bacterial vaginosis. It's not an inflammation. It's just a lot of like white, smelly discharge kind of stuff. And this can happen when the pH of the vagina changes. And again, when you're on testosterone, the pH will change. You can also get what's called atrophic vaginitis. And that's the condition that we talked about, where the skin is thinner and more delicate. You can see right here, this inner area, it's pale. It doesn't have as much, mucous membranes. It's a pale skin. It's very delicate and it's more fragile. Now, this is a yeast infection, and you can see the white, clumpy, curdy bits of yeast. This is very inflammatory. It's very itchy. It's burny. It can cause a lot of discharge or no discharge. The amount of discharge with a yeast infection is totally unrelated to the degree of inflammation inside. And again, you don't really have nerve endings inside like that. They're on the outside. So if you get, a lot of itching and irritation, it could be a yeast infection. You should be seen. The other thing that can cause a lot of discharge and itching is something called trichomonas. And that is, it's a little organism. It's a single cell organism that's passed through sex. It causes a thin, watery discharge that feels like urine leaking, but it's not. And this, again, can kind of do the loop back and forth between partners. Both partners should be treated at the same time, really to get rid of it. And they're really easy. They're all easy to treat relatively. But you need to be seen because, again, the telephone is neither a diagnostic nor a therapeutic tool. If you're assuming that if you call up and say, I have a yeast infection and they're giving you all kinds of meds over the counter or whatever, or calling in prescriptions and it's not better, you need to be seen. Again, you don't know what you need to have an accurate diagnosis in order to treat it appropriately.
I know this is a real problem right now with COVID because so many physicians are trying, healthcare networks are trying to do virtual phone-based visits or video visits.
Yep.
And my wife actually is a healthcare provider, and no one wants to be, dropping their pants, on over the internet, right? So, it's important, that you really advocate for yourself. Say, no, I need that in-person visit.
Right. Or sometimes there's some things like that we've done over the phone. So, certainly if somebody has a lot of itching on the outside, you can ask them, do you have any discharge? If you do, what is it like? Is it thick? Is it thin? Is it itchy? Is it burny? Does it hurt all the time? Are there any open sores there? Because again, herpes is another thing. And I don't have a picture here, but you can get little herpes ulcers. They're little punched out ulcers. They are super, super painful. And it's painful all the time. Whether your underwear touches you or touching your hands or going to the bathroom or whatever, it just hurts all the time. Unlike some of the other stuff where you just kind of had red raw, irritated. If you have a discharge, does it any unusual smells, any pain with sex, things like that. So, those kinds of questions can sometimes help. And if a provider wants to try something over the counter, it has to be with the caveat that if it doesn't work, you need to be seen. And don't mess around with it. Don't keep using over the counter stuff. We had actually somebody who used over the counter wart preparation for genital warts, and it was something that's made for harder, thickened skin rather than that, fine, delicate genital skin. And it was compound W, I think, and they gave themselves a terrible, terrible burn. So again, don't make assumptions like that because you're afraid to see a provider. Talk to somebody. Even if it's on the phone, you got to talk to somebody. Do not use over-the-counter products for that, okay? And again, urinary tract infections. Honestly, you need to be careful with these also, because we have people that call and say, it burns when I pee. It burns when I pee can mean all kinds of things. It might be a urinary tract infection, but that same thing as a bladder infection, but usually symptoms that come along with that is as soon as you're done urinating, you feel pressure and like you have to urinate again. And this happens again and again, even though just a little bit comes out. It's different from the urine hurting as it goes over an open sore. So as much information as you can provide on the phone is really helpful if you're going through a phone triage. They may ask you, do you have any sores that you can see around the outside? I understand you have to be just about a contortionist to be able to see external genitals, but usually with a mirror you can try. And sometimes just with your hand touch.
And I know that, trans folk get UTIs at a rate significantly higher than the cisgender population, like 8 times the rate. So it might be a good time to talk about just things you can do to prevent UTIs.
So for urinary tract infections, first of all, remember, if you're a trans guy, you're going to have that little short urethra unless you've had bottom surgery. So you're going to have a little short urethra. And so what you need to do is urinate before and after if you're having insertive sex. You really need to urinate. You also need to very carefully wipe from front to back all the time, rather wiping the other way, because bacteria can get up that little urethra. Also, with oral sex, really be careful and wash really carefully afterwards, because again, the bacteria from the mouth can go up that little short urethra. And urinate afterwards, but lots of water. Don't let yourself get dehydrated. So those are the kinds of things that can certainly help. So pelvic pain, I think this is a really interesting topic, and it's so poorly understood. It's really poorly understood in trans men. There seems to be a testosterone impact, especially something called post-testosterone cramping has been identified that people don't really understand, but after the administration of testosterone, people can get pelvic cramping. They can't physiologically. I've not been able to find an etiology for this, and I've been looking again. Some folks also get orgasmic pain, or anytime that they have sexual arousal, they can get this pretty incredible pelvic pain. And there's been all kinds of theories, things like pelvic congestion syndrome and whatever, but nobody really understands. So if you are getting pelvic pain, first of all, make sure if there's any possibility that you could be pregnant. Again, even on testosterone, unless you've had your uterus and ovaries removed, if you are having sex, insertive sex with a partner with a penis who ejaculates, it's possible you can get pregnant. Now, again, testosterone does suppress ovulation most of the time, maybe not all of the time. So that, again, depends on the dose of the testosterone, the route of the administration, all those kinds of things. You need, make sure that you get a pregnancy test. Be screened for infections. There's something called PID, or pelvic inflammatory disease. When I went to school, we used to call it pretty inadequate diagnosis. Any person who had a uterus and pelvic pain were the first suspicion was that they had some type of sexually transmissible infection in the uterus. So again, make sure you get screened. It might be a cyst on an ovary. It might be any number of things. So, again, make sure you follow up on that. And the follow-up doesn't have to be a pelvic exam. So if you're afraid of a pelvic exam, it doesn't have to be. You can learn a lot from an ultrasound. So ultrasound on the abdomen, not even, an internal ultrasound. Make sure you get infection screenings. You might want to switch to a patch or transdermal testosterone. Sometimes that can help. And they've talked about using progesterone hormones as a way of stopping this orgasmic pain. And again, it's so poorly understood. So I think they're kind of shooting in the dark there. But if you're going to undergo another hormone like progesterone for this, I think you need to be under the care of somebody who's skilled in prescribing that for this specific issue.
We have somebody who's asked a question, and it may be coming up. So if so, just say so. But looking for advice about trying to get pregnant at some point after stopping.
Coming up. Yeah.
So it's coming up. Perfect.
Coming up. So persistent bleeding. And this is a problem. So again, there is a testosterone effect. And usually, monthly bleeding stops in about 6 months on testosterone, on what's considered a therapeutic dose of testosterone. But again, that depends on the dose, how often you get it, whether you get it through the skin, whether you get it by mouth, whether you get it injectable, and your body size. So a lot of that really depends. And it also may depend on your individual testosterone and estrogen levels. And the reason we say that is, again, when you take testosterone, your body converts part of it to estrogen. And that's just what happens in the breakdown. And also, if you happen to be bigger, if you happen to have more weight, what happens is your fat cells actually produce estrogen. So, you can have more estrogen there. So that can cause persistent bleeding. But you also might have some internal anatomical issues that could be polyps or cysts or fibroids or even cancer. So, if you have not bled in a while and start to bleed, you really need to follow that up. Or bleeding after 6 months, check in with someone. Again, it doesn't necessarily mean an internal exam. An ultrasound usually does the trick. And again, you may want to consider different types of progesterone treatments. Now, frequently, what I've used is the progestin IUD. And I've used it for lots of things, but, it decreases or eliminates menstrual blood loss. Significantly. And some folks can actually have, you see this term endometrial ablation. And what they do is they destroy the lining of the uterus so it no longer bleeds. So that's another option that can be done. And then, of course, there's hysterectomy. But again, when you look at all of these types of approaches, I think you always have to look at risk versus benefit. And that's something that you would have a conversation with your provider.
And with getting these types of treatments covered by insurance, once you've had name change and your gender on your insurance is male, I'm guessing that you may need to get pre-authorization and have your doctor, fight on your behalf.
Yep.
Yeah.
Yes, absolutely. So pregnancy. So I think before anyone starts testosterone therapy, they should have a conversation. And you may not even know at that time whether or not you even think about pregnancy in the future. But certainly you need to think about the risks of pregnancy. If this is not something you're planning at the time and you're having receptive sex, you need to take precautions, right? So what we know is 1/3 of all pregnancies in trans men are unplanned. They're all surprises. So just because you're on testosterone, again, doesn't mean that you can't get pregnant. So there are things that you can do to decrease your risk. And again, they also decrease your risk of bleeding as well. So that's progestin-only pills. And that could be something called SLIN that actually shuts down your ovaries. Other progestin-only pills do not do that. There's only one in the market right now that actually shuts down the ovaries from working, so they don't release an egg. There's also something called Depo-Provera, that's DMPA, and that is an injection you get every 3 months. Now, the issue with that is most people, again, it works very, very well for preventing pregnancy, but some people can have some irregular bleeding with that. The progestin IUD is very safe and effective. It's like 99 point something effective in preventing pregnancy and also stopping bleeding. So these things can actually work together, but you really do need to think about something to prevent pregnancy and not assume that you're not at risk. So if you decide you want pregnancy, or you might want pregnancy in the future.
So we do have a question before you move on.
Oh, sure.
That is, can you use estrogen-based IUDs?
There are no estrogen-based IUDs.
Okay. There we go.
Yep. So, there certainly are fertility options, and it's helpful to have this conversation with a provider before you begin testosterone. You might want to have some eggs frozen. Again, this is a conversation to think about. But if you decide that, if you're on testosterone and all of a sudden you've met somebody that you think you want to raise a child with, and you want to experience this pregnancy, you can do it. The recommendation is you stop the testosterone for 6 months. And usually it'll require some fertility medication. You will need a really good support team, and a good medical team together to help you with this, to help you, lots of folks. You can either have artificial insemination or insemination by a partner with insertive sex. There's a couple of ways you can do this. You can use an egg that you froze and, use artificial insemination later, where they can actually insert the fertilized egg in your uterus, and then you can carry the pregnancy. But again, you're going to need good medical support. Oops. Sorry, I thought I had another slide on pregnancy there. But this is the kind of thing that, is highly specialized. And, again, with pregnancy, I've taught midwives over the years, the last 20 years. And many trans men feel really uncomfortable going to traditional OBGYNs for care during a pregnancy. I can tell you that a lot of midwives right now that are currently in or recently graduated from programs are trained in the care of people across the gender spectrum, and that includes pregnancy care. And many trans men choose to see a midwife for pregnancy and birth. So this is something that can be worthwhile to explore. There's also really good support teams, support groups that are out there for trans men. But it's really, specialized care at this point. And you need to make sure that you have good resources. So I would suggest there are some sites where you can reach out to for more information if you decide that you'd like to get pregnant. But certainly reproductive endocrinology is a place to start. So
I'm sorry. I said I do know that there are, and we have people that come on these webinars from all over the country, but in our local area in Allentown, there are clinics specifically that offer services for trans folk. And
right.
If anybody is looking for information on that, I can make a connection. You can send us a contact form through our website, and we can connect you.
Great. I just want to thank you for spending this time with me. And I think, again, I put these two photos on the last slide because, these are folks who have gathered the attention of the world now. I mean, to be, for Adrian Dowling to be on the cover of Men's Health is really significant. And now Elliot Page to be the first trans man on the cover of Time. Again, I think healthcare for trans men is evolving. Social care, support care for trans folks is evolving. But a lot of this is happening because of you all who are being advocates for yourself, but also for the healthcare providers. So know that healthcare providers are trying really, really, really hard in a world where we don't have a lot of, I would say, a lot of good research, good peer-reviewed research, that isn't just anecdotal. Corinne and I were just talking before we started this, that so much of the information out there is anecdotal, and you folks talk among yourselves and then you hear crazy stuff and it keeps you out of care. So I think you have to, again, try and identify providers that are going to give you factual, informed information and really good care.
Yeah, and and I'll just say again, if people go to either the Eastern PA Trans Equity Project website, patransequity.org, or the renaissancelv.org website, which is our support group website, we have links to all kinds of trans affirming healthcare providers in Eastern Pennsylvania, and we're adding more pretty regularly. So please check it out. So I'm gonna kind of take a pause and let people ask some questions. And we do have one, and I'm not sure if this is in your wheelhouse, Wendy, but so somebody's asking, so I'm just going to read the comment. Sure. So some states won't allow hormone therapy for adolescents until the age of 16. I know hormone growth suppression can prevent development of secondary sex characteristics, but are there other ways that providers can support patients through that? So adolescent patients who are going through puberty, because
you mean
it can
hormone
be
blockers.
Yeah. So there are hormone blockers. Then there's masculizing hormone therapy, but maybe there's other things that we can talk about as well.
Yeah, unfortunately, that's really not in my area of expertise. So I'm gonna pass on that. I don't want to give that information.
Well, and what I will say is that in our experience working in advocacy work, there's you can't open the newspaper or the internet nowadays without seeing news stories about all these legislative efforts to block affirming therapies for trans kids in particular, and the good news is that in Pennsylvania, where we are, there are none of those bills. And although there is one legislator who is talking about introducing one of those bills, it's very important that, number one, people understand that the federal government under the Biden administration has, essentially, said that, if you take federal money, and there isn't really a large healthcare network out there that doesn't take federal money in the form of Medicare and Medicaid, that if you take federal money, you have to be able to provide affirming care, number one. So it is likely that these laws that you hear about are going to be they are going to be challenged in court, and they will be put on stay, as the one in Idaho, for example, has. But it's also very important that we advocate on behalf of these kids, write your congressperson, write your state legislators, and, make sure that they know how important this is, and that they need to understand that hormone blockers, are largely reversible, right? They just stop puberty from occurring. They don't create any permanent changes. And then, once somebody, hits the age of majority, which in some states is the age of 16, other states is 18, then that patient is legally deemed capable of making an informed decision. The other thing that I would really encourage people to think about is trying to avoid clinics that do a lot of gatekeeping. So there are healthcare providers that use an informed consent model, where they will make sure that everybody understands all the risks. but they don't necessarily require everybody to jump through lots and lots and lots of hoops. And you can search, under informed consent, healthcare and find those providers. So that's my non-healthcare provider words of wisdom. So we'll wait a moment or two to see if anybody else has any other questions. But Wendy, any kind of, if you had a moral of the story tonight, what would that be, you think?
Find a good healthcare provider and actually get regular care. Episodic care is better than nothing, but it's not the best. So really see if you can, find somebody that you can communicate with and you can trust, and develop an ongoing, professional relationship with a good provider.
Yeah, it's okay to doctor shop.
Oh, absolutely. Absolutely.
Yeah. So looks like Amadi is going to type a question in the chat. So we're going to wait a second or two while Amadi does that. So, we're kind of talking about doctor shopping, but, when you find that doctor, and I know I personally have gone through this, where I had a horrible healthcare experience with a doctor, and now I have a doctor who I'm very comfortable with, and it can make a big difference. And so in terms of getting that regular care, so I'm not afraid to go in for a checkup where, before I didn't go back to the doctor for 4 years, which is really bad for a fat person who's pre-diabetic. So, okay, so here's a question. Are eggs damaged from prolonged HRT use?
HRT, you mean?
Hormone therapy.
Hormone therapy.
Yeah, testosterone, yep.
Oh, I see. Not to my knowledge. Not to my knowledge. And again, well, what happens is you actually have more eggs when you're born than you do when you reach reproductive age and capacity, so you have a natural dying off of the eggs as you grow up. So, you're more likely to have them die off just from sheer aging than you are, I believe, from hormones. And again, the testosterone, as far as I, am aware, should not harm the eggs.
Yeah, I think that, but you do want to make sure that you are off testosterone for a period of time
6
prior
months,
to
yep.
trying to,
Right. And then again, they're probably going to give you something that's going to stimulate ovulation. And so usually it's that you have to be seen by a reproductive endocrinologist in order to do that.
So it's not so much that the eggs are damaged, it's that the sort of the process of getting the egg to move, and I'm not an expert in this stuff, but to get where it needs to go is where we kind of run into challenges, right?
It's also like if you're a trans man and you're not having insertive sex, you can shed all the eggs you want and nothing's going to happen to them, so to actually retrieve the eggs and do artificial insemination is certainly one avenue, but you don't have to do that. You can create more eggs. What it does is just increase the amount of eggs that are going to reach maturity so that you have a better chance of pregnancy. But of course, then you might wind up with twins, or triplets. So that's always something to think about.
Sure. So
I see a comment here about the IUD for the past 8 months, and it's causing a lot of bleeding. So there's a couple of different kinds of IUDs out there. One IUD is a copper IUD that does increase bleeding. The other one, the progestin IUD, should actually pretty much stop bleeding. So it might depend on the type of IUD you have. You have the progestin one. Okay, well, again, I would say if you have a lot of bleeding with that, I would be concerned about placement maybe, and it might be worthwhile to have an external ultrasound done just to make sure that it's in the right place before yanking it out. But SLIND, you can try it. It's pretty expensive. It's a hormonal contraceptive, but the people that I know that have used it actually like it. But again, it has to be on your insurance formulary, and there's a whole other barrier.
So step 1, ultrasound. Step 2,
negotiate,
with the insurance company. Yeah.
Right.
And that's something that we intend, we're negotiating with somebody right now and trying to get somebody who's going to come in and talk about how to appeal with your insurance company and how to argue with your insurance company.
Oh,
So
great.
hopefully we'll have that coming down the road. We've kind of had a lot of medical things lately, so we're trying to intersperse a little bit. But yeah, it's important, I think, to make sure that you understand that you are the customer and you have a certain amount of power
Great.
as the customer. Yeah.
Right. And again, I mean, I see this as people with equal power, you know what I mean? So the healthcare provider has a specialized knowledge in one area, but you are the expert in your own life. So, together you should be able to develop, mutual goals. But they need to be a shared kind of power situation.
Yeah. All right, so we'll see if anybody else has a question. But in the meanwhile, Wendy, I'll just say that it's always a pleasure working with you. So thank you very much.
Thanks so much, Corinne, and it's so good to see you.
Yeah.
And again, if anybody wants, again, I am kind of semi-retired at this point. I'm still working as adjunct, so I can kind of work when I want. But you're welcome to shoot me an email. And what I don't know is, make sure you copy Corinne on it, because she probably has a lot more information, especially on support structures and things like that than I would. But I'm glad to take any emails.
Absolutely. Thank you so much. Yeah,
so
here we go. Here's a question.
So
you mentioned chest exams are still needed, even post-mastectomy or top surgery. Is there also still a risk for ovarian or uterine cancer that patients and providers need to be aware of?
Yep, absolutely. That's why you got to know your family history. And again, if you've got problems, you need to bring it to somebody's attention. And again, with chest exams, you don't need one every year. You may want to, when you first meet a provider and you've had top surgery, you may want to have the provider familiar with, again, your scar tissue and the way your chest is now configured, so that if any changes come up, they'll be noted. But again, if you notice anything, you need to bring it to their attention.
Yeah, and so, and then they were also asking about uterine and ovarian cancer. So there's still a risk of that as a trans guy. Yeah.
Right. And ovarian cancer for sure. Lots of those are genetic. Uterine cancer certainly can be, because if you're stopping ovulation, and especially if your weight is on the upper end and you're making estrogen, you're having estrogen stimulation to the lining of the uterus, but you're not ovulating to shed it off. So, there are some issues with that, but that's rare from the literature that I have seen. That is rare. But it is possible. Again, uterine cancer is not the kind of thing that's usually associated with genetics.
So that might be just a good thing to kind of talk about for just a second, is that
sure.
Many trans guys that I know tend to put on bulk, right? They put on weight. And the more weight you put on, the more estrogen your body naturally produces.
Well, that depends on the type of weight. So the trans guys tend to put on more muscle rather than fat. It's, it's all related to the fat. Okay.
So don't get fat like me.
No, it's just where the adipose is. We ladies have our, the estrogen gives us, fat pads. Testosterone gets rid of the fat pads, but gives you muscle. So, yeah. So.
Great. And thanks, Amadi, for sharing that information on the Facebook group. That's great. Thank you. All right. Well, we have overstayed our time by a few minutes, but again, Wendy, I just want to thank you so much for investing your time with us tonight. And for those who arrived a little bit late, we will be putting a copy of this video up on our YouTube channel. It'll probably be up by the end of the week, so you can always go back and take a look at that again, and slow down and pause and take notes if you want to. So thanks everybody for coming out tonight. Wendy, thank you so much. You're a champ.
Thank you. Good night.
Bye, everybody.